Hello, everyone. My name is Alana, and today I will be presenting on sexual and gender-based violence on a global scale. So for the outline, we will first go over a brief introduction to sexual and gender-based violence on a global scale, and then do a PHR spotlight in which I will interview representatives of Physicians for Human Rights. So here's a quote capturing how sexual and gender-based violence is a public health crisis from the World Health Organization Director General. Violence against women is endemic in every country and culture, causing harms to millions of women and their families, and has been exacerbated by the COVID-19 pandemic. But unlike COVID-19, violence against women cannot be stopped with a vaccine. We can only fight it with deep-rooted and sustained efforts to change harmful attitudes, improve access to opportunities and services for women and girls, and to foster healthy and mutually respectful relationships. So it's important to know that violence against women can take multiple forms. This includes intimate partner violence, sexual violence, female genital mutilation, forced and early marriages, femicide, and trafficking. So here are some statistics on a global scale. So 1 in 3 women are subjected to physical and sexual violence. This disproportionately affects low and lower middle income countries and regions. So 37% of women aged 15 to 49 living in countries that were classified as least developed by the Sustainable Development Goals have been subjected to IPV in their life. Whereas 22% of women living in these countries were subjected to IPV in the past 12 months. This is compared to the world average of 13%. So here are some statistics on intimate partner violence. So worldwide, about 27% of women aged 15 to 49 were subjected to physical or sexual violence by their intimate partner if they were in a relationship. And 25% of girls aged 15 to 19 in a relationship have experienced intimate partner violence. As well as 38 to 50% of murders of women are committed by intimate partners globally. So clearly this is a very serious public health crisis. So here are some statistics on sexual violence. Globally, 6% of women report that they have been subjected to sexual violence from someone other than their husband or partner. But this is likely a very significant underestimate because there's so much stigma related to this issue. And 15 million adolescent girls worldwide, aged 15 to 19, have experienced forced sex, and they are most at risk of forced sex at the hands of a current or former husband, partner, or boyfriend. So what are the risk factors for intimate partner and sexual violence for those who are going into medicine to look out for? These include lower levels of education, history of exposure to child maltreatment or violence, witnessing family violence, harmful use of alcohol, community norms that ascribe higher status to men, low levels of women's access to paid employment, and low levels of gender equality. In terms of risk factors specifically associated with IPV, these include a history of exposure to violence, marital discord, difficulties in communication between partners, and male controlling behaviors toward their partners. Factors specifically associated with sexual violence include beliefs in family honor and sexual purity, ideologies of male sexual entitlement, and weak legal sanctions against sexual violence. And these risk factors were outlined by the World Health Organization. So what are the health consequences, again outlined by the World Health Organization? So for OB-GYN, there are various concerns or various health conditions that are related to experiencing such violence, including STIs, and they are 1.5 times more likely, unintended pregnancies, induced abortions, miscarriage, stillbirth, preterm delivery, and low birth weight babies. As well as for psych, they're more likely to experience depression, PTSD, anxiety, sleep difficulties, eating disorders, substance use, and be more at risk for suicide attempts. So here you can see a figure that was put out by the World Health Organization. So globally, women who experience partner violence were twice as likely to have an abortion, 1.5 times more likely to acquire HIV, 2.3 times more likely to have alcohol use disorder, and twice as likely to experience depression. Other health consequences include injuries. So 42% of women who experience intimate partner violence reported an injury due to such violence, as well as fatal outcomes as discussed earlier, including homicide or suicide. Other health effects include headaches, chronic pain syndromes, GI disorders, and limited mobility. So in sum, if you're seeing patients who endorse any of these concerns, it is always important to keep such partner violence on your differential. And here you can see another figure by the World Health Organization that describes violence impact on, or how violence impacts women's mental health. It includes injuries, depression or anxiety, sexually transmitted infections, self-harm or suicide, unwanted pregnancy, or substance use. So in our last kind of bit of this intro, we're going to go over the World Health Organization's health sector objectives and how this aligns with our curriculum. So the first objective is to generate evidence on what works and on the magnitude of this problem. And that will be addressed today on the sexual and gender-based violence on a global scale. And you will hear from members of Physicians for Human Rights on how PHR is documenting such violence. We will also talk about the second goal, which is the second goal of the World Health Organization, to provide comprehensive services and to sensitize and train healthcare providers to respond to the needs of survivors. This is discussed in the documentation of sexual violence, as well as in trauma-informed care in April. As well as the third point is to advocate to make violence against women unacceptable and for such violence to be addressed as a public health problem. This will be addressed in how to serve as an effective student advocate, as well as the prevention of recurrence of violence through early identification will be discussed in the documentation of sexual violence in the earlier lecture in February, as well as the talk on sexual and intimate partner violence. So now we will transition to discuss a little bit more about Physicians for Human Rights work in this area with a PHR spotlight. Welcome to our first PHR Spotlight. In this series, we'll be highlighting advocacy work done by Physicians for Human Rights. And today we will be focusing on PHR's work advocating for asylum seekers who survive domestic and gang violence. A brief background for today's session. Under the Trump administration, immigration policy became increasingly restrictive. Notably, former Attorney General Jeff Sessions ignored decades of domestic and international legal precedent by issuing a statement that domestic and gang violence survivors will not qualify for asylum. In order to document the harms of such a policy, PHR analyzed 132 medical legal affidavits resulting from medical and psychological evaluations of asylum seekers. Via these affidavits, PHR documented instances of domestic and gang violence experienced by asylum seekers and the physical and mental health effects of such trauma, as well as the resilience of survivors of trauma. These findings were used to generate a report entitled Profiles in Resilience: Why Survivors of Domestic Violence and Gang Violence Qualify for International Protection. So today we are very fortunate to be joined by key representatives of this project: Kathryn Hampton, who is the Deputy Director of the Asylum Program, Phr, who is a medical student currently at the University of Washington, and Dr. Eleanor Emery, who is an internist. Thank you all for joining us. So we will dive right in with questions. And first, we're going to focus a little bit on the findings of the report itself. So the first few questions are going to go to you, Kathryn. And so the report describes the prevalence of domestic violence and gang violence. Can you please tell us a little bit more about your findings in regard to the prevalence of such human rights violations?
Yes, thank you so much for having us to speak to you about our research, Alana. We looked at the stories in medical legal affidavits for domestic and gang violence survivors, because a lot of people in the US have a lot of misconceptions and preconceptions around people who are seeking asylum for these reasons, and saying, you know, oh, well, we have domestic violence everywhere, so they should just go back to their country, or, you know, thinking that just because someone is targeted by gang violence, that means that they're, you know, a threat to the US, or for whatever reason they don't deserve asylum, and their asylum claims have really come under attack. And so that's one reason we wanted to do a deep dive and really understand, okay, what is this population? What have they been through? Why are they coming to the US? And it will be no surprise to medical students who have probably shadowed many of these kind of evaluations that we found that very high levels of trauma, people surviving physical violence, sexual violence, witnessing murders and other violence. So very, very high levels of trauma and abuse that they survived. And also a high incidence of mental health conditions that Phr and Dr. Emery can also speak about.
Thank you so much for sharing that. According to your report's findings, to what extent is there a relationship between gang violence and gender-based violence?
So what we saw in doing a qualitative content analysis of these affidavits is that actually there was often some kind of thematic relationship between domestic and gang violence, whether it was, a father or a brother or a spouse or boyfriend or, other person in your family or your life who's joined a gang or trying to leave a gang. That was often interrelated. So there was not so much of a clear-cut line, and a high percentage of people experience both gang violence and domestic violence. Other ways that the two types of violence can be interrelated are, for example, the son is being recruited into a gang, and so other family members are threatened, or they want to take the young daughter of the family as a girlfriend of a gang member, and so if she's resisting, then other family members might be threatened, or similarly, any different types of family members can be targeted or kidnapped or harmed as a tool of coercion. So there's a real enmeshment socially and relationally with the gang and domestic violence.
Yeah, thank you for that very important insight. And the report also describes various psychosocial dynamics of abuse. I know that was a major focus of the report. What are some highlights from your research on the ground with regards to such dynamics of abuse?
I think another important aspect of the report, which it draws out, is the connection between communities and government response, and then the acts of violence that are being perpetrated, and that kind of cyclical nature where you see, police officers who are either they normalize domestic violence or they're afraid of gangs, and so they turn a blind eye. And in communities where victims are shamed for, having been violated instead of supported by the community, they're judged. So all of these different dynamics can really combine to create a situation where there's no way to find protection in your home community because your neighbors would blame you for being raped. The police, think that you should just put up with it because you're a woman or because you're gay or because you're some other group, and that's just how the way things are here. And so that was really a strong theme throughout all the interviews, that it's like there isn't anywhere you can turn. You can't just move to the next town. You can't, there's no other avenue for you to find protection from this violence.
And thank you so much for your insight, Kathryn. So now we will shift to Dr. Emery. So the report we have also describes the physical and mental health effects of trauma. Can you elaborate a bit on the findings?
Yeah, of course. So we looked at 132 affidavits in total. The majority of those, 101, were for mental health evaluations. So our report primarily comments on the mental health impact of the very extensive trauma that we documented and that Kathryn discussed. So in the 101 mental health evaluations, 79% of those clients were determined by the provider conducting the evaluation to meet criteria for a DSM-5 diagnosis, the Diagnostic and Statistical Manual of Mental Disorders, which is the defining resource in mental health. The most common one of those was PTSD, which was met in 68% of cases. And the next most common was depression at 38% and generalized anxiety disorder at 10%. So those are much higher rates than in the general population, of course. When we compared that with the literature on other immigrant populations fleeing conflict or displaced populations, it's within similar realm as those populations globally, but certainly at the higher end of the rates of mental health impact that we saw in other similarly traumatized populations. So in sum, this is just a population that has experienced a lot of trauma, and they bear evidence of that in the form of the mental illness that they carry with them when they migrate. Importantly, suicidality was also very common. So 32% of the people reported any history of suicidal ideation or attempt, and 13% at the time of the evaluation in the US were still reporting suicidality. So a very morbid condition, obviously. Interestingly, of the affidavits that included a mental health evaluation, so those 101, 42% of the people reported that they'd had an improvement in their mental health symptoms or their general well-being by the time of the evaluation. And that was usually specified to have happened since migration to the US. So we saw that even though there's a very high rate of mental illness, migration in and of itself, these people had not yet gotten asylum in the US. They were undergoing that process, but migration to a safe country such as the US can provide healing for many people, almost half of the people in this sample.
That is wonderful to hear. I think that there is the possibility for healing once these people find safety. I'm kind of building on that. I do think sometimes people conceptualize the immigration as if there's trauma and then you move to a country and then there's no longer any trauma, even though, as you guys have documented, there continues to be trauma that this population faces in the United States. Can you talk a little bit about what types of ongoing trauma in the United States this population faces once they're living inside the United States? And what are the mental health impacts of such ongoing trauma?
Absolutely. So one of the key things that we wanted to look at was the rates of trauma that happened both during migration, which we know is a very vulnerable period for people, and also after arrival here in the US. The limiting factor is that most sort of traditional forensic medical evaluations focus on trauma in the home country because the goal is to establish that past persecution has happened. So many affidavits don't comment on the migration process or trauma here in the US. But even despite that limitation, in the sample, we found that 46% of the people in the study reported ongoing trauma after arrival in the US. So that's almost certainly underreported, and it's still almost half the sample. The types of trauma that they experienced included both sort of ongoing threats from their home country, so persecutors contacting them via Facebook or phone in the home country, or threatening family members or children who'd been left behind, but also new types of trauma here in the US, especially gender-based violence. So a lot of reports of domestic violence by new abusers or intimate partners here in the US, sexual assault in the workplace, even a few examples of sex trafficking happening here in the US. So it's not quite, we like to think, as you said, that people arrive and the problem is fixed, but unfortunately, our data showed that we have a lot of work to do to actually make this a safe country for people who are arriving. And importantly, most of our sample had, most of these evaluations took place before the Trump era. So this was before Remain in Mexico, this is before Title 42. And so you can only extrapolate and imagine how the trauma that one might experience while they're waiting in a border camp on the Mexican side of the border due to those policies would be exponentially more than somebody who is waiting in New York City for their evaluation to take place. So I think it's a key highlight from this study, and definitely warrants ongoing study, especially now, given these restrictive policies in place at the border.
Yeah, thank you for your insight. And my last question for you in this part of the session is that there seems to be a huge burden of adverse mental health outcomes related to the trauma that these survivors have faced. What should physicians or future healthcare providers take away from these findings when taking care of our own patients?
So many of us take care of immigrants, whether or not we know it. And some of these may be asylum seekers, but there are many forms of immigrants, and many routes to seeking safety in the US that aren't asylum. And so I think the key thing to be aware of is just the very high rates of trauma that this population has experienced, not just prior to migration, but even after arrival here. Studies have shown that physicians don't ask about trauma nearly enough, and yet it can underlie many of the diagnoses, both physical and mental, that we see in practice. So we're really missing a huge piece of the story if we don't ask these questions. A lot of people who work in this field and with immigrant populations recommend asking to all patients where they're from and also why they came here as just a simple screening question to sort of get a better sense of who's migrating as a result of trauma. And in these times, anybody coming from, especially the Northern Triangle countries, but areas in Mexico and South America, if somebody has migrated, there is a high likelihood that they did so as a result of various types of trauma, whether it be sort of economic problems or gang violence, domestic violence in their home countries. So it's worth us asking about those as providers.
Thank you so much for sharing. I think you're exactly right that screening for trauma is so important, especially as we try to move towards a more trauma-informed care model. And so kind of shifting to Phr a bit is, I found it very interesting that various resilience factors were also described in the report. Can you share a bit about the report's exploration of survivors' resilience?
Yeah, and I kind of want to emphasize before I kind of get into the meat of it, the resilience factors weren't evident in every single affidavit. So it was kind of a limited variable, but very, very important, especially to Dr. Emery and Dr. Richards, who kind of headed up this project, or at least oversaw me. So resilience factors, there was limited information about it, but the information that we did have was really, really rich. And it painted a picture of how important it was for when asylum seekers do arrive in the United States and are able to kind of wait for their trials and wait for their cases to be heard, how important it is to have access to things like a church or friends or even family if they had family here prior to migration or if they migrated with their family, work, education, all of these things that are so important to just any human being. And I think it also showed an additional avenue of violence if they were barred from those things, if they didn't have the ability to see a doctor or they were terrified of seeing a doctor, if their trauma kind of prohibited them from leaving the house or, anything like that. So it painted, or it kind of demonstrated how important it was to make sure that we connect asylum seekers with these resources once they do arrive. And I think there are a lot of great resources in most cities that offer those services, but at the same time, even if those services are offered, it's still really difficult for people to access them. So, it was really, really interesting to explore that a little bit more. The data was a little limited, so I'd be interested to see and, learn more about this from papers that are able to explicitly ask that question of asylum seekers. It was kind of, if it came up in the interview, the provider included it. And I actually will hand it off to Dr. Emery to see if there was anything else she wanted to add to that, because resilience was a really important factor that we talked about towards the end of the report, once we had finished the analysis, how important it was to touch upon that.
Yeah, I think that's exactly right. The key thing to note, sort of similar to the ongoing trauma in the US, is just that the right place to analyze this is not in these forensic medical affidavits, because it isn't traditionally the focus of those. So the fact we were able to sort of glean some suggestion about the importance of these, but really dedicated study focused on interviews with people who have migrated and what factors have supported their recovery is needed in order to help inform our approaches. We spend a huge amount of resources in sort of helping with assimilation or turning immigrants into productive members of society. And what we are learning is that the best way to do that is to capitalize on the resilience factors that these people already identify as promoting their health. And we don't have great dedicated data to inform those policies yet. So this was just a very sort of early way of looking at that.
Yeah, so I think it's So wonderful that you guys highlighted the resilience factors, as I think that is, as we all know, that's pretty rare to focus on in research or in the literature. So definitely more studies are needed on resilience, and perhaps a possible area of research for any medical students that are watching and might want to become involved. So my last question in this section goes to Kathryn, and this was asking about what were some of the resulting advocacy efforts that were informed by this report?
The biggest outcome that's changed since we published the report is actually that the Biden administration reversed the Trump policy that first moved us to do this research, which was the Attorney General certified a case to himself, matter of AB, that really basically sought to deny access to asylum to many domestic violence and gang violence survivors. So this evidence was a part of speaking out from the advocacy community and part of convincing the Biden administration to overturn that precedent. But we also sent the report to the Department of Justice and the Department of Homeland Security, and all of the researchers, including Dr. Emery and Phr, met with a number of senior officials at the Department of Homeland Security, including members from U.S. Citizenship and Immigration Services that do a lot of adjudication. And we had a really in-depth conversation with them about these issues. And they were actually very moved. One of the attorneys who was on the call was moved to tears thinking about what the asylum seekers have been through and about the importance of providing protection for them. It was one of the most impactful policy meetings I've actually ever had. I guess that just the research and the stories just really struck them, and you don't usually get that kind of personalized response. So I think that was really a testament to the power of the findings.
Yeah, thank you all again so much for sharing this information, as well as for continuing to advocate for asylum seekers. This is such important work, and it's so wonderful to see PHR doing this work. So now I'm going to focus a little bit on questions that will allow the viewers to learn a bit more about your team's specific roles. And so again, I'll start with Kathryn. So can you tell us a little bit more, and I think you've kind of touched on this a bit already, about why and how PHR became involved in this project?
Yes, well, it was part of a trend where PHR is trying to collaborate a lot more with our medical school clinics and with people in our network, experts in doing joint research projects, and really seeing how we can combine kind of that PHR advocacy lens with the amazing, talented researchers who are part of the asylum network. And we continued that. We worked with Alana on a project at the US-Mexico border, opposing Title 42. So we feel really privileged to just have the opportunity to partner with medical schools. And then basically it was this particular decision by the previous Attorney General, Jeff Sessions, who just had this absolutely draconian and nonsensical, ruling that, just even practically as an aside, as a dicta said, oh, domestic and gang violence survivors, most of them won't even qualify for protection. And that was overturning decades of precedent. And it was just such an egregious, move on his part to deny people the protections they need and that they deserve. And so we were really determined to see what the PHR case record might be able to say about that, because we knew that the majority of our clients are actually fleeing domestic and gang violence.
And thank you for sharing. What was your role in this project as the Deputy Director of PHR's Asylum Project?
Well, I think just partnering with our amazing researchers. I wasn't doing any of the quantitative analysis, but some PHR staff worked a bit on some of the qualitative analysis, and also the data collection and curation, and kind of diving into our case record and seeing, what's there and how can we filter out these cases. We filtered out specifically cases that had received asylum. So they were clients who had received asylum mostly prior to this, this negative precedent under the Trump administration, and then helping to develop the advocacy targets and the policy analysis that would kind of flesh out, what we're trying to say in the policy realm.
Wonderful. So what do you think the role of healthcare professionals should be in advocating for asylum seekers and other marginalized populations?
I think health professionals really have, two things that really make them extremely credible voices in the advocacy space. And one is just the expertise. Clinicians are seen as people who are, very highly trained, who are experts, who are basing their investigations on scientific principles. And so it's really a unique lens to approach a problem. And also it speaking through health professionals in advocacy also really humanizes the discourse, because we've all been to the doctor. We've all had that moment where we're sick or we need help, and the health professionals who've really, evaluated asylum seekers, I mean, those are people who've really heard firsthand these stories and bring a lot of that heart and that emotion, because a lot of these policy attitudes and decisions that people are making, it's not always purely logical. There is that emotional element where you have, a prejudice about a certain group, or you start to forget that each of them is an individual person with an individual story. And I think that's something that health professionals really bring home in a powerful way.
And how can interested students, particularly medical students, become involved in PHR's work?
Well, we have medical student clinics at, I think it's now 21 schools. And there are a lot of schools that have really great medical, asylum clinics that aren't even partnering with PHR. So definitely check at your school. I think now there are at least 40, maybe even 50 medical schools that have asylum clinics. So, that might be a possibility at your school. And then we also have PHR Student Chapters. So student chapters don't work directly with asylum seekers the way that clinics do, but they do a lot of awareness raising and other activities where you can really kind of get that hands-on perspective about, what is human rights? How is it relevant, for me and my community and my country? And then there's the annual PHR Student Conference, which is always, I think, really, really inspiring and a great learning and networking experience. So yeah, I think there are so many ways.
That is wonderful to hear about all the opportunities for medical students to become involved with PHR. So now transitioning to the medical student on the team, Phr. So I know that you joined this project as a public health student and then have continued this work as a medical student. Can you share a little bit about why you decided to join the project?
Yeah, I mean, it first started as a public health student. I was really interested in immigrant health generally in the United States, prevention, treatment, things like that. And through time, I became really interested in working with refugees and asylum seekers, given, I think Dr. Emery mentioned this earlier, how much the trauma that they experience underlie the diagnoses that are made later in their life when they're here in the United States. I had a really personal interest in this work as well. My parents, well, I'm a first generation Southeast Asian woman in the United States. So, I grew up in a community of immigrants and knew how important it was to understand these issues a bit better. And I kind of stayed on the project because of all the reasons, I had just mentioned. I was still really interested, I think, as a medical student and as a physician, I also plan to keep doing this work. I think it's really important. It's really rewarding. And at the end of the day, it's really nice to have people that look like you doing these evaluations and doing this work. And I think it's really, really important for other, first generation medical students to keep doing this work as well.
Wonderful. Thank you for sharing. And what was your role in this project as a student at the time?
Gosh, I did a lot of different things. I was mainly there to help with data extraction and data organization, and Dr. Emery and Dr. Richards, they had the research questions in mind, and they, had kind of said, this is how we should frame this and that. And I kind of went in and just organized a lot of the work and did a lot of the data extraction and worked with a lot of other great medical students who helped out with data extraction and coding and things like that. And there were a lot of other students, not just me, who worked on this project who were super, super helpful, designing the survey on Qualtrics and, things like that. So I wasn't the only one, but I kind of did more of the data coordination role and also helped out with the qualitative analysis.
And what advice would you have for medical students or students in general who are interested in advocacy work?
I think, volunteering with your local student-run asylum clinic is a really great way to start. That's kind of what I've been doing as a medical student. It's a different side of this type of work. And I think it's advocacy in and of itself. Volunteering to be a scribe for forensic medical evaluations is so important and gives you just as much, if not more, insight than doing research, because you're in the room, you see the emotions, you see, the real human impact of a lot of the violence that they've overcome. And I think it was those experiences that when I, left the room have followed me into the clinic. And whenever I see patients or patients have mentioned that they're immigrants or that they've only recently come, it's the skills that I develop in those evaluation rooms that, come out with me.
And what will you take away from your experience with PHR that will inform your practice as a future physician?
Well, I hope to continue working with PHR. Our clinic, actually, the clinic that I work with isn't affiliated with PHR, though we work with them a lot. But I hope to, do evaluations one day. I hope to continue advocating for asylum seekers and refugees in whatever way that might be. That might be more reports, that might be more, doing the evaluations. I think it's shown me that advocacy can be so many different things. It can be writing reports like this, but it can also just be volunteering your time as a provider to do the evaluations itself.
Wonderful answer. I think it's so important to recognize that advocacy can come in so many different forms. So thank you so much for your work as an advocate. And so then to Dr. Emery, a kind of similar line of questions. What encouraged you to become involved in this project as a physician?
So I started working with PHR as a med student in 2010. I was at Cornell's asylum clinic, new asylum clinic at that time, WCCHR. And there's been this interesting evolution during that time period where, I think PHR has taught me as much about my career as med school has, because it was sort of informing the way that I think about being a physician since the very beginning. But there's been this interesting evolution where I think I got hooked initially because you have so little power as a med student, but doing these evaluations, I saw, I remember the first case where one of my mentors at Cornell took me to the New York City courthouse to see the verdict read for a young woman that we'd evaluated. And when they told her that she'd been granted asylum, it was like, oh my gosh, I have a skill set that can impact somebody's life. This is totally nuts. It didn't, I hadn't had that experience with prescribing a medication before or anything. So it was the first time I really felt like this is why I went into medicine, was so I had these skills that allow me to have an impact. And I've always loved that about doing this work and about medicine in general, but especially in these really desperate times, like I was feeling during the Trump administration, it feels like helping one person at a time is not enough when you're faced with these, with these huge policies that are just undermining human rights kind of across the board. So suddenly there was this element of sort of being disconcerted with those one-on-one encounters. And I really wanted to do more at the level of public health, where I felt like I could impact, it was more upstream and had an impact on more people at a time. And so this was a way to sort of move in that evolution into a role where we were looking at the population level. And again, it was completely informed by my experiences in these one-on-one encounters. I could tell that the narratives, as Kathryn said, of that were in the public and being espoused by the president of who these people were not correct based on my experiences with them. But in order to say that at a population level, you have to do research. So I was fortunate enough to have a number of people, including my partner in this work, Dr. Adam Richards, who was at UCLA with me at the time. And also Phr had a number of skills as a result of being a public health student that I didn't have in research. So we were able to sort of partner on this project and look at multiple dimensions of the data, including through quantitative and qualitative analysis. And then having Kathryn as a policy expert on the project also was totally instrumental in terms of when we were deciding which themes we wanted to look at in the qualitative data. She was able to say, one of the things that one of the grounds, the ways that you qualify for asylum is you have to prove that you couldn't seek safety elsewhere in the country. And so it's really important that we pull out that theme, which is something that I wouldn't necessarily have thought of from a medical perspective. So having that combination of expertise between the medical establishment and PHR and their policy skill was a really unique experience. And lastly, I would just say the cool thing about this project was that one of the problems I've had with research, especially in this sort of human rights vein, is that I think when we put it out there, I often worry that the only people reading it are my colleagues who already agree with me. Like who else is reading the Journal of Immigrant Minority Health, which is where we published this paper. But because we were partnering with PHR, we put out both an advocacy report and an academic paper using the same data. And that really just exponentially increased the impact that our findings had, because I think it reached a different population. As Kathryn said, we were able to meet with people in the government and policymakers. So I would really encourage people to it takes a long time to do this type of project. And so any way that you can increase the impact of your work by, for example, by working with a group like PHR, I'd really encourage other physicians and researchers to look into those partnerships.
Emery, I think that was, such an insightful commentary about the importance of advocating for your patients, both at the individual and at a larger level. So what do you think the physician's role is in advocating for marginalized patients?
So I think that we have a responsibility to use, sort of, as I was saying, to use our unique skill set to translate the kind of unique access that we have to people and their stories as these trusted interlopers in people's lives to the general public and people in areas of policy and governance. I think that the important thing to remember is that we aren't taught, I think that's a critical element of medical professionalism. It is not something that medical education trains us to do. So you don't go through medicine and come out on the other side like ready to speak to the media about these things. I think that's unfortunate. I think that the current situation that we're in has shown us that science is really, it's not enough to just stand there and state the science. There's so much sort of contention and science denialism that we need to learn specific skills that allow us to advocate on the basis of our scientific knowledge. And again, that's not part of standard medical education. So I think that there's the few ways that I would really recommend building those skills are, I have a background in community organizing, and I think that that is a really key skill set. It emphasizes the importance of story, which is interesting in asylum work because we do so much work with people's narratives, but it teaches you a set of leadership skills for how to advocate for change effectively by building relationships and bringing people together. And again, that's not something that we learn. So however it is, whether you learn to really effectively write op-eds or, communicate research sort of in layman's terms or whatever it is, figure out your skill set that will allow you to make that bridge and then cultivate that just as much as you cultivate your sort of scientific foundational knowledge.
Wonderful. And how can physicians become involved in similar advocacy work for any physicians who might be viewing this video?
So obviously partnering with PHR is a really wonderful option. We used PHR's database of affidavits, as a number of other groups have done. And so that's a tremendous resource of a national sample of affidavits. They have case outcomes for many of those. So it's a great way to access the narratives. There's also a group now, the Society for Asylum Medicine, that's run by a few of my colleagues. That's a listserv that's very active. And there's a lot of both sort of discussions about forensic medical evaluations and advocacy work in this field that are discussed frequently on that listserv. So So that's a great option too, but, or of course, working with many of the institutional asylum clinics, the student-run clinics and other clinics are trying increasingly to engage in some level of research and policy work. So, so I think those are all great options. I did want to make one plug, Alana, if it's okay, for I think the specific advocacy objective that has really come out of this project for me, and that we've done some work with Kathryn and other colleagues in the policy realm, especially from Phr on, is the amendment of the INA, the Immigration and Nationality Act, to add gender as a sixth ground for asylum. This would be a huge push, but I think is sort of one of the questions for people in our time in the space. As Kathryn mentioned, this project really highlighted the overlap between, the common denominator amongst people seeking asylum on the basis of domestic and gang violence is gender-based violence. The majority of applicants, I think 77%, identified as female. Of those seeking asylum on the basis of gang violence, over a third of those had also experienced intimate and partner violence. So there's tremendous overlap here. But the irony for us is that after we read these narratives, which are clearly narratives of gender-based violence, if you look at their form on which they're applying for asylum in the US, they aren't applying on the basis of gender because that's not an option. They're applying on the basis of this membership in a particular social group, which requires a much higher evidentiary burden to prove the claim and are historically much less likely to qualify for asylum. So it's a question for us all that I think Kathryn and others in the field speak really eloquently about how this harkens back to the fact that we didn't recognize gender-based violence as a thing when these international agreements were first written, and just shows how ingrained misogyny is in our history, and therefore in our policy and laws. So I think, one of the questions for people in the field in our time is, will we be able to do this important work of adding gender as a ground for asylum in the same way that race and nationality and these other immutable characteristics are already considered to be.
And just out of curiosity, and for our viewers here, what ways can people become involved in this really important work?
So Kathryn can probably also speak to that. The group that has been most active that I'm aware of is Phr, which is a policy organization that works a lot with gender-based violence issues. There's a woman, Irina Sullivan, who we've worked closely with on a number of talks and presentations. We're giving another one in April about their sort of advocacy work around this issue. They recently, I think on their website, it was months ago now, I guess not that recently, but published a brief about sort of the specific ask for the INA. So I would direct people to Phr as a great organization doing this work. And PHR has also done some, is supportive of this issue. So Kathryn, I don't know if you have any other sort of venues for people on that topic in particular.
Yeah, I think Phr is a great example. They have a number of offices throughout the country. If you go to their website, I think it's TAHIRIH is the name of the organization. And so, you can follow them on social media, you can sign up for their email list and see ways to get involved. Another organization that works a lot on gender and refugee issues is the Center for Gender Refugee Studies at UC Hastings. And they even have an expert witness database, which is kind of similar to PHR's list. So if you really wanted to hone in on gender, you could potentially also sign up for a CGRS as well.
We will make sure to add those links and organizations to the end of this video, so the viewers who are watching, look out for that at the end. So thank you all so much for your time and for answering my questions. And thank you to our viewers for your interest in this project. If you'd like to read the report generated, we will add that at the end of this video, as well as various other links where you can learn more about PHR and this important work and how to become involved. Thank you guys so much.